Good morning, ladies and gentlemen. Thank you for this invitation to speak. Timothy already greatly opened the topic, so we will try to follow. So we will see how MR imaging impact in clinical routine and in research topics for vascular disorders. We have, as Timothy already said, two points to develop. First, MR imaging was used to depict clearly vascular disorders. And we are going now through risk stratification. So for the depiction part, we have most 2 or 3 clinical situations. The first, the patient coming in emergency with the sudden headaches and a suspicion of subarachnoid hemorrhage. We call that a thunderclap in a calm sky. So in this situation, what we want to know is there an aneurysm? Is there a vascular disorder that is responsible for the subarachnoid hemorrhage? And then we have 2 other clinical situations where the patient is stable. It's the screening part. Is there an aneurysm because the patient has a polycystic kidney disease, which is known to be a higher risk of presenting aneurysm, intracranial aneurysm, or, for example, when there is a family history of subarachnoid hemorrhage. And the third part is follow-up of treated patients. For the risk stratifications, we have, for the past decade, developed morphological criteria and also natural history of aneurysm evolution and arteriovenous evolution. And we are moving towards individual criteria of rupture risk, with the question, should we all stand up against the wall? And we will see it a little bit later. So I will try to precise those 2 questions, depiction and risk stratification, for all of the 3 main vascular disorders, aneurysms, AVMs, and fistulas. Let's start with the aneurysm. So, current clinical diagnosis is largely based on luminographic techniques that depict the lumen of the vessels. For aneurysms, mainly 3D time of flight is used. It's a simple T1 weighted sequence optimized to maximize an existing inflow-based contrast. At the slab exits, inflowing spins present a residual saturation that locally results in blood signal loss. We call it here the Venetian blind artifact. Multiple overlapping of thin slabs are used to address this issue and to cover correctly all intracranial vessels from the posterior inferior cerebellar artery to the pericallosal artery. We need a large field of view, and it is feasible when using 4 to 5 slabs. The use of 3D scans have demonstrated their superiority compared to 1.5 Tesla scans. And still there are some very good papers showing that with optimized parameters you can accurately diagnose even small cerebral aneurysm, less than 5 millimeters. The counterpart is that the sequence in this case lasts 9 minutes. So, as Timothy said, increasing numbers of aneurysms are detected because of the wider availability of imaging techniques. Here's an example. A 45-year-old woman coming for dizziness. We found on 3D time-of-flight image an anterior communicating artery aneurysm. It doesn't explain the dizziness, so it's a fortuitous aneurysm of less than 3 millimeters. Shakespeare would have said, to treat or not to treat? That is the question. So what do we know? The prevalence of aneurysm is around 5% in the general population. 5% is still a great number of potential patients. We know that the annual risk of rupture is around 1%. And that the rupture with subarachnoid hemorrhage is a severe complication with 45% of mortality within the first 48 hours. So it's a rare event, but a really severe one. On the other hand, if we wanted to treat all the aneurysms, what would we have? We know that their treatment, whether surgical or endovascular, is at high risk. The cumulative rate of morbidity and mortality between 3 and 10% depending on the technique used. So all aneurysms discovered cannot be treated. So the decision to treat is actually based on a case-by-case basis, including both the risks of natural evolution and the risks of treatment. Let's stop a little bit on this study, published in Lancet Neurology 2014. In this study, which is the phases study, it's a recent pooled analysis of individual patients from 6 prospective cohort studies where predictors of rupture were geographical region, hypertension, tobacco use, age, a previous history of personal subarachnoid hemorrhage, and now criteria that can be assessed using MR, aneurysm of more than 7 millimeter in size, and their localization, vertebrobasilar, anterior communicating arteries, and posterior communicating arteries. Most aneurysms are small, with inherent low risk of rupture, and are therefore left untreated because the risk of complication of preventive treatment does not outweigh this small risk of rupture. But still, in absolute number, many small aneurysms do rupture. This is an interesting study too. They looked at people presenting subarachnoid hemorrhage with the question, was the biggest aneurysm the cause of the bleeding? Remember David and Goliath? And in that case, 1/3 of the patients with aneurysmal subarachnoid hemorrhage and multiple intracranial aneurysms, in 1/3 of them, the ruptured aneurysm was not the largest one. And so they proposed to identify morphological criteria, what we call the aspect ratio, which is the neck to dome length divided by the neck width. And if this aspect ratio is superior to 1.3, and if the aneurysm has an irregular shape, then it is at higher risk of rupture. However, aneurysms with identical morphology and same patient profile can be stable or unstable, remain unchanged for years, or rupture. So we really need to move towards specific marker of rupture risk. 2 main orientations are suggested in different studies. First, studying the flow, or via 4-day flow MRI, or thanks to computational fluid dynamic. And as Timothy said, mostly the 4-day flow MRI are phase contrast sequence that use the change in the phase shift of the inflowing protons to create an image. Now we have sub-millimeter spatial resolution. This is the PC Viper reconstruction, allowing to see vector field velocity, so the orientation of the blood flow in each voxel of the aneurysm, weighted with the velocity of the moving spins. And also we can reconstruct wall shear stress, for example, which is on great debate on different studies. We will come to this. Vessel wall MRI has also becoming more and more implicated in detecting potential inflammation of the wall. We will speak about the USPIO, ultra-small particle of iron oxide, and of the use of 3D-T1 Fespinico sequence to detect cerebral intracranial aneurysm enhancement. So let's start with the 4-day flow MRI. It has been validated. The first question is it valid to look on the reconstructions that are given with the data coming from 4-day flow MRI? It has been validated on phantoms, on animal studies, and for example, here we looked at the qualitative analysis allowing to delineate the flow pattern within aneurysms when comparing digital subtraction angiography with a temporal resolution of 0.5 seconds, where you see here on this giant aneurysm of the anterior communicating artery, the inflow, and also the outflow of the flow going through the aneurysm. And we correctly correlated the pattern of flow, the recirculating pattern of flow, with the streamlines visualization of the past taken by the streamlines post-processed 40-floor MR sequences. So what has been said on different studies is that from a qualitative point of view, a compact inflow jet, a small focal impingement zone, and a high vorticity should be higher risk of rupture of the aneurysm. There still is a great deal of debate to know whether wall shear stress, high or low, could be linked to an independent factor of rupture of the aneurysm. So wall shear stress represents the frictional force exerted by the flowing blood tangentially on the vessel lumen. High spatial resolution is necessary to accurately acquire wall shear stress at the boundary zone of the vessel. The boundary zone of the vessel is probably the highest challenge when reconstructing wall shear stress maps. Moreover, you know that the wall is pulsatile, and so that is also an issue. So can we really measure a wall shear stress? In fact, we have apparent wall shear stress. But it is still really interesting to study it, and the interaction between intra-aneurysmal flow and pathobiology of the wall and aneurysm geometry is promising. And probably the idea would be to be able to know when aberrant hemodynamics can disrupt balance towards aneurysm growth and rupture. Okay, let's go to the imaging of the wall. So vessel wall imaging and inflammation has been known for years thanks to histopathologic evidence, and inflammation is known to have an impact on initiation, growth, and rupture of the aneurysms. I also quote the same article, stroked to 2012 from Hassan, where they show that early change in ferromoxital enhanced magnetic resonance imaging suggests unstable human cerebral aneurysms. So they infused ferromoxital, which is an ultra-small particle of iron oxide, 24 hours before the imaging, which was the T2 star gradient echo sequence. And they looked at early changes in the walls of cerebral aneurysms. Normally, 24 hours after infusion, you should not have this dark line surrounding the wall of the aneurysm. But still, it is not really easy in clinical practice to use the infusion of USPIO 24 hours before the imaging. So we had the opportunity to test 3D fast-spin echo T1 sequences. It was initially developed to characterize thin enhancement here, for example, in metastasis. But thanks to variable flip angles, we saw rapidly that it had an inherent black blood effect that could be used to study the wall of arteries and veins. So the first application was using it to better depict cervical dissection, here carotid artery dissection with the hematoma, seeing hyper T1. And so the idea here was that, okay, there's a black blood effect, so the lumen is dark. The cerebrospinal fluid is dark too because it's a T1. So the interface between the two should be the parietal wall. So we know that normally there is no enhancement of the parietal wall of normal vessel. You see here the pituitary stalk, which is enhanced, showing that this is post-gadolinium. And so we looked how it worked on parietal wall of aneurysms. We dichotomized two groups of patients with a study of a little bit more than 100 aneurysms, stable aneurysms and unstable aneurysms, which were ruptured aneurysms, symptomatic aneurysms, or modified in size between two MR controls. And interestingly, we could describe this enhancement, the global cerebral arterial wall enhancement, which was an independent factor linked to the status of the aneurysm. Okay, so it was also used to depict the origin of the bleeding. Here you have a patient with subarachnoid hemorrhage visible on hyperflare intensities from the cisternal basal cisterna and the Sylvian sulci. And you see there is not only one, but four aneurysm, superior cerebellar artery, M1, and the bifurcation M1 and 2, the right Sylvian artery and the left Sylvian artery. Which one has bled? The localization of the blood can help, of course, because you see it's more oriented on the left part of the brain. But interestingly, on those four aneurysms, and specifically those two which were about the same size, the right one did not enhance, whether the left one did clearly enhance. And so on different studies, and especially the one of Matuk here, it was said that it could be a hint, a help, a clue to see which cerebral aneurysm was the one that ruptured. So monitoring aneurysm in 2015, we still have to know morphology. We don't have to forget the basis, and we're moving on to vessel wall imaging and flow imaging with the idea of combining the two techniques to better understand at which step of the evolution the aneurysm is. Okay, so let's now move to the AVMs. For depiction of AVMs, 3D dynamic time-resolved, contrast-enhanced MRA has really changed the way we used MR in clinical routine. It is used to depict and also for the staging, knowing the arterial feeders, the nidus, and the drainers. It was possible because of the K-space undersampling and synchronizing the acquisition with the arrival of the contrast agent. And so the first tricks images here, for example, I'm sorry the film doesn't go, but had an impact on patient care because before the year 2000, people with arteriovenous malformations had a DSA per year for their follow-up. And now they have an MRA each year. So it really had an impact on patient follow-up. As Timothy said, there are more and more new techniques that are developed because although TRICS has been shown to provide reliable information for Spätzle-Martin grading, a compromise between spatial and temporal resolution is necessary to maintain image quality. So in our clinical routine, our TRICS image has a temporal resolution around 1 second, and it remains insufficient to detect reliably all potential risk factors like deep venous drainage, venous ectasia, intraneedle aneurysms, and venous stenosis. So we're using also a sequence which is a hyperflow sequence from medicine, which is a highly constrained back projection with phase contrast as a constraint MRA sequence, and it uses phase contrast, which gives an angiogram to constrain the time-resolved acquisition after a gadolinium injection. So thanks to this technique, we now have a temporal resolution of 0.5 seconds. We can also use a lower quantity of gadolinium, half dose, and you see that the arterial diagnostic window, which shows the ability to clearly identify the arterial phase from the venous phase, which is really important in AVMs, is better here depicted than with TRICS, for example. And so in this study, they showed that deep venous drainage was clearly better identified. Here on TRICS, you cannot say whether you already have the sagittal sinus, which is opacified, and you see here the deep venous drainage, but you cannot say if it is part of the AVM drainage or no. Whether here hyperflow and here GSA, both of them could clearly identify deep venous drainage in arteriovenous malformation. Venous ectasia is also another challenge that is better depicted because of the embedding of the spatial resolution, and venous stenosis. What do we know about natural history? You now all recognize the CN Tower. So 2 main studies from Toronto and from Helsinki. So natural history of AVMs show that the risk of bleeding is higher in the first few years after the diagnosis of brain AVM. It is also very important to take into account the global, over one's lifetime, the global risk of bleeding, cumulative risk of bleeding. For example, if a patient is young, 20 years old, and has a long life expectancy, you see that the risk of bleeding can be really high. But we already said that this Aruba study showed that when they compared interventional versus conservative treatment, they had a higher than expected event rate in the interventional group. So they had to stop earlier, and the follow-up was of 3 years. So the question is here again, how do we select patients who would have a benefit at being treated? Can imaging help us? There are interesting papers that showed the application of new techniques of enhanced time-resolved spin-labeled MRA. So we could say intravessel ASL, showing different patterns from 2 groups, ruptured arteriovenous malformations and unruptured AVMs. Here you have time arrival maps with an eccentric time arrival maps versus concentric time arrival maps inside the nidus. This sequence is quite interesting because we can study the nidus, which was not really possible with the other sequence that I showed you, like the PC Viper sequence. So it gives some clues. Here it's also, this is from one patient that we imaged with the PCASL from Madison. Which is interesting is that normally you should not have draining pathways that are showed here because we're on arterial speed flow. And we clearly see really easily that the deep venous drainage here is recruited by this huge frontal AVM. We can also use techniques as photo flow MRI to monitor the decrease of flow information prior to morphological change. Here on arterial feeders of an AVM. We can also look on venous drainage if the impact of sterile treatments before and after treatment. You see here that the nidus size has decreased. If the impact of that treatment make significant change in the flow and speed of venous drainage. Okay, and finally, for dural fistulas, it is close by AVMs, but dural fistulas are a direction between artery and veins, and contrast-enhanced MRI are used to see abnormal arterialized venous structures like this. But still, it is not really easy to depict, so it still is a challenge for us as neuroradiologists. And it is important because they are potentially at high risk of bleeding. So when we used the photo flow MR imaging, we thought that we could also track the flow from close to close and to have like selective MRA. So this is the post-processing that you can see we tracked, we labeled on each carotid and vertebral arteries, and we followed the flow from close to close until the shunt here, and then the venous drainage and the sagittal sinus. Though here it's really easy, thanks to this technique, to see that there is an abnormal connection between arterial structures and venous structures. So we really did that like selective angiography, and we could, with this technique, have an Borden or Cognard classification, MR classification, of all the different subtypes of the dural fistulas. It is important because we know that type 2B, 3, and type 4 are at higher risk of rupture. So now that we can not only track fibers but track the flow, we have here the first application of risk stratification of avascular disorders. So to conclude, do you remember when you used your phone just to pass phone calls? And do you know now how your phone is indispensable in your life? Especially, you can rate us, for example. It is a little bit like this. We have the morphology, and we really don't have to forget that. But we have new tools. We have wall and we have flow imaging. So probably a quantity of amount of data that we have to take into account, with the final aim, which is not to have beautiful images, but which is clearly to work for the good of the patient. So the idea is now to move towards individual marker of rupture risk. And I would like to acknowledge all my colleagues from the St. Anne Hospital Center, the University of Wisconsin, with Patrick Tursky, Oliver Ribben, Kevin Johnson, and Wu, who are really helping us in this collaborative on all those collaborative studies, and the ASNR Vessel Wall Imaging Group. Thank you.